Hey everybody, I'm Trista Reed. I am the program director here at UNC for the General Surgery Residency program. The purpose of this slide deck is really to give y'all a view into what the program is like, a little bit of a background so that the day of interviews we can actually focus on questions and go over a little more in-depth things around the program. Um, I have been here a long time at UNC. I was a medical student here, and then I did my residency here. And I went away for a year for fellowship and then came back, and I've now been here 7 years as an attending. Um, I was in the associate program director role for several years from about 2017-18, and then took over the program director role this year from Dr. Mike Myers. Um, the reason I have stuck around so long and why I love UNC is one, the well-roundedness of the program, the significant complexity of the patients, with a pretty large underserved population, but most importantly the people. I would say the people are the number one thing that brought me back. While in surgery there's always a hierarchy, I felt like it was less so at our program. There's a lot of camaraderie among the attendings. The residents work and play together and basically function as a family. Um, and the attending resident relationships are really great. So the residents feel like they can reach out and approach us, even at the lower PGY levels. So without further ado, I'm going to go ahead and get into it. This presentation will kind of go over the history of UNC, go through the healthcare system overview, Department of Surgery background and leadership, and then go into more detail on the program. So faculty, training and education, research, the residents, and then a little bit about the area of Chapel Hill. So UNC is one of the oldest public universities in the U.S. There are about 29,000 students, and a lot of those are a large amount of graduate students. It is a top 10 university in terms of research funding. As you can see, the number is listed out here. And a large amount of the federal and NIH funding is between the School of Public Health and School of Medicine, so we're contributing significantly to that. The School of Medicine was founded a long time ago, back in 1879, and the first memorial hospital system was built in 1952, and here's a picture of it. And the location of it is pretty ideal. You can see, I don't know if you can see my cursor or not, but right here is where the hospital stands, which is next to the football stadium on campus of UNC proper. And so this is what the health system looks like today. The UNC Medical Center has the Cancer Center, the Women's Hospital, Women's and Children's, and then the old Memorial Hospital. And currently over next to the Memorial Hospital on the left side of the screen is where the new surgical tower is being built and will be opening this spring, which we are incredibly excited about. Because we're not for profit, we get a large amount of uninsured patients with very complex surgical problems. The UNC health system is not for profit, 15 hospital system across North Carolina, and also includes a Hillsborough campus. So this is part of the UNC main, but is about 10 miles away down the road. And this is where the current PGY2s go for some bread and butter surgery and get some robotics exposure. We also have an educational affiliate, Wake Med, in Raleigh, which is a large level 1 trauma center in Raleigh that actually gets a moderate amount of penetrating trauma, lots of bread and butter general surgery as well, and the residents really enjoy that experience. So this is just another overview of the UNC Health Sciences campus, and there are a lot of different schools involved with it. So we have the School of Medicine, School of Public Health, School of Nursing, School of Pharmacy, Dentistry, the Lineberger Comprehensive Cancer Center, and the biomedical graduate programs. And so all of those schools being in close proximity to each other leads to a lot of cross specialty and school collaboration available to us. One thing that's a little different from our institution compared to some other institutions is that the funding for the School of Public Health and School of Medicine are separate, so you may notice that if you're looking at our funding sources. So we have a long history of strong leadership in the department. Dr. Tony Meyer, who's our chair from 2001 to 2016, is still operating and still part of our department and is a great resource. Dr. Melina Kibbe really increased our research mission here at UNC and is currently the dean at UVA. And then Dr. Greenberg came and is our new chair as of 2022, and she's absolutely amazing. She spent many years at the University of Wisconsin and was the prior chair at the Medical College of Georgia. She has a lot of amazing ideas around video feedback and coaching that she has brought to our department already. I'm sure you'll get to hear more from her about all this on the interview day. So the current Department of Surgery organizational structure is broken down into the following divisions. GI surgery, which is minimally invasive and colorectal, surgical oncology, pediatric surgery, abdominal transplant, which is important to note here. We do liver, hepatobiliary, renal transplantation, islet cell transplants, which Dr. Desai, who's our chief of that division, has brought to UNC. It's a really unique opportunity for residents. We also have a trauma and acute care surgery division, burns, which the PGY 1s and 2s rotate on the burn service, and it's a great experience as well. Vascular, cardiothoracic, and plastic surgery. So now I'm going to go into a little bit of our program overview and structure of the program itself. So I'm currently the program director. I took over the reins from Dr. Mike Myers, who was the program director here for 11 years. He's one of my long-standing mentors and is an incredible clinician and educator. He stepped down from the PD role this year to be promoted to vice chair of clinical operations for our department, which it's really wonderful to have him in this role because he's a strong advocate for the residents. He's graciously agreed to be my associate program director for the rest of the year to kind of smooth that transition. He's one of our surgical oncologists and, like I said, an amazing educator in the OR. The other associate program director is Dr. Ariel Perez, who is also just an incredibly wonderful human being and is really, really engaged in resident education. She has focused on curriculum for simulation, and developing robotics in the hospital system as a whole. She's one of our hernia surgeons here and has been really, really instrumental in advancing our educational opportunities for the residents. So the training program at UNC is a 5-year clinical training program. There are 7 categorical positions. We have an optional research and academic development time. And I think this is one of the great things about our program is that flexibility. So you can go straight through and just do 5 years of clinical training, or you can take an optional, not compulsory, not mandatory, 2 years of development and research time. Generally about 3 to 4 residents per year take advantage of this, so about half of the program. This will occur after PGY 3 year. The primary goal of our clinical program is basically a comprehensive clinical training. We want to foster independence, so our goal is to make independent surgeons in and out of the operating room and develop leaders. So these are, some of the goals of the training program by year, and I'm not going to go through all of this, but obviously during PGY 1 year, we want patient management to be a focus, but our PGY 1s do get in the operating room. We want them to learn basic operative skills, and we really encourage them to get in the OR early on in their PGY1 year. As the residents kind of graduate with responsibility, we really do try to start giving responsibility as chiefs on certain services early on. So the second years rotate in the ICU or in charge of things in the ICU with some supervision from the fellows and the attendings on the trauma critical care service. During the PGY3 year, likewise, we really strongly encourage the PGY3s to have these leadership roles on certain services that they're on, including when they're out at Wake Med and the transplant service. And that's all in anticipation of them becoming team leaders, independent in the OR by the time they graduate, which I think we do a good job of. This is the breakdown services by year. So for PGY1, the services are 1 month. You will rotate on GI, minimally invasive, oncology, pediatrics, trauma acute care, and out at Wake Med. Subspecialty rotations include the burn unit, thoracic, vascular, transplant, and the surgical ICU. The rotations get a little bit longer during PGY2. During your PGY2 rotation, there is an ICU night float system in which the residents are the ones in charge at night. And you do have obviously backup, but you're by yourself trying to troubleshoot, and I feel like the residents grow a lot during that time when they're in the ICU at night. You'll rotate through GI, minimally invasive, and hernia service, oncology, trauma acute care, Hillsborough Hospital, which is that experience where you're getting to do a lot of bread and butter surgery and some robotics. Wake Med, surgical ICU, vascular, thoracic, and burn surgery. During the third year, the duration of rotation is usually about 8 weeks. You're rotating through pediatrics, colorectal, oncology, which is mostly endocrine, Wake Med, again, in which your responsibilities start to graduate to a chief level responsibility, transplant, and vascular surgery. PGY4 year, again, longer rotations. You're rotating through oncology, which is mostly colorectal, minimally invasive, endoscopy rotation, trauma acute care surgery, Wake Med, and senior in-house rotation, where you are the one in charge at night. And then PGY5 is focused on lower GI, oncology, breast and melanoma, oncology, GI and hepatobiliary, pediatric surgery rotation, hernia and general surgery, acute care. And then we've incorporated an elective rotation for the chiefs, which they really love. And that's what I, again, love about this program is the flexibility. So you can really pick anything that you want. So pediatric surgery, thoracic, plastics, whatever you're going into and you have an interest in learning more about before you become a fellow, that's completely fine with us to do that rotation. We even had somebody who went to Malawi for a month, which was kind of difficult logistically to figure out, but we were able to do it. So training from an in-house call standpoint, so the PGY1s do about 1 night a week of 24-hour call. It's rotation dependent. We have in the past tried to do a night float system, and we've kind of gone back and forth about that. The residents currently have given us feedback that they prefer the PGY1 24-hour call rotation during the week as opposed to a night float system, so that's how we currently do it. The PGY2s basically are on call 1 night per week plus the ICU night float rotation. One of the things that we're talking about doing based on feedback from the residents over the past couple of years is expanding the night float to include the consult resident so that the PGY2s are doing less 24-hour call. And so that's something that will likely roll out next year. PGY3 is a night float system specifically at Wake Med. If you're not at Wake Med, there's some home call on the different services that you rotate on. But at Wake Med, it's night float, 12-hour shifts, probably average every fourth night, and they do a week at a time of this night float system out at Wake Med. PGY4 is generally about 1 to 2 half days per month when you're a senior in house, which basically just means you're kind of in charge of all the consults coming in during that weekend 12-hour shift that you're doing. They are 12-hour shifts. And then there's a weekly night float rotation as well, which is that senior in house responsible person who's on during the weekdays. And then PGY5 has about 1 to 2 half days per month, again 12-hour shifts on the weekend where you're covering. From a resident attrition standpoint, our attrition rate has been 8.5% since about 2002. But one of the things that we're really proud of is if you look back from basically 2011 onward, we have had nobody leave the program. National averages approaches about 15%. I think the fact that nobody's leaving the program is really a testament to the faculty. The resident-faculty relationships are really great. There's a lot of collaboration across levels. The faculty are very approachable. The residents enjoy training here, and because they enjoy training here, they don't decide they want to go into a different specialty. They stick with it and really enjoy the experience. And now I'll get a little bit into our operative experience and what that will look like. So we have a really robust surgical experience here, and I believe that's across PGY levels. So our PGY1s get in the operating room. Most of the chiefs, by the time they graduate, have somewhere between 1,100 and 1,200 cases. This is our operative experience in terms of major cases by graduating chief resident over the past several years. The RRC minimum is 850 cases. That's this green line that you see. I do think it dropped off a little bit over the past year or so just because of COVID, where we had operating rooms shut down during that experience. But still, the people who graduated in 2023 still had above 1,100 cases as their minimum. Here is the average number of chief cases, which means the chief residents are the ones running the show, and they're in the operating room. And the RRC minimum is a minimum of 200 cases, and obviously we're consistently above that as well. And like I said, I do think COVID has affected some of the numbers, but not significantly. Here are the index cases that are required by the RRC. So the dark blue are the minimums. If you can see these dark blue lines, that's the minimum for each of these categories. And then the light blue are what our graduating chief averages are. And as you can see, we're well above averages across the board. I would say, we don't have a huge number of liver and pancreas cases, but in general, we do get about twice the RRC minimum in spite of that. Where we really seem to thrive, and one of our strong suits, is alimentary and open abdominal cases, and also complex laparoscopy. There are currently not minimums for robotic surgery, so that's not on here. If you ask me, what a program weakness is, that's one area that I think we've been weak before in the past in terms of getting our residents exposure to robotic surgery. But true to one of our strengths, where we actually take resident feedback really importantly and grow the program in areas that we feel like we need to, that's something that we're aggressively working on, is expanding our robotic footprint. So we have a goal currently to have all our graduating residents get their robotic certificates this year. And I'll touch a little bit more on this in the education part about how we're trying to do that really thoughtfully. I think I mentioned this before, but one of our strengths is our graduated autonomy. And so a lot of these, major cases, the residents are the ones doing the operations and are getting a lot of experience. So now we'll move on to didactic education, and then I'll talk about simulation. So this is just a view of kind of what our departmental and divisional conference schedule looks like. Not all these things happen every single week, but the chair has quarterly meetings with the residents. I, as the program director, meet about once a week or every other week with a different group of residents, be it the PGY1s, the 2s and 3s, or the labs 4s and 5s, on a rotating schedule, basically to get feedback and figure out how to improve the program. Tuesdays we have Journal Club, which is about once a month, and the residents present different articles. Wednesday in the mornings, M&M and Grand Rounds, that's every week, from 7 to 8 o'clock. And then from 8:15 to 10, it is resident didactic education, fully covered, protected time. Pagers are covered by APPs and fellows and other people. And so this is really the education time for the residents. Sometimes during that time as well, we add on ABSITE and board test review, as well as oral board, mock oral style discussions. Thursday is simulation labs, usually in the morning. The residents rotate through simulation, and that includes things like chest tube placement, central line placement, vascular anastomoses, bowel anastomoses, robotics curriculum, and things of that nature. We have a new lunch case-based conference with quarterly video review conference that's being added in on Thursday at noon. And then a lot of the divisions have their own divisional M&M or case-based conferences throughout the week, and whoever's rotating on those services goes to those conferences. Like many programs, we use SCORE portal for our surgical training curriculum. And so this is basically a portal that gives you both questions around the topic of the day, as well as basic reading, so that you know the most up-to-date papers on the subject that we're talking about, and like highlights, bullet point. Usually we split the juniors and seniors into two separate groups, and there's an attending with each group kind of going through the curriculum for the day. We do have a clinical learning and research center, our simulation lab, which we are actively revamping. That is headed up under the leadership of Dr. Ariel Perez, who's one of our associate program directors. She's been really, really instrumental in getting residents involved in simulation, and as I already discussed, that includes vascular anastomoses, bowel anastomoses, regular events that the residents get to participate in. There is a dedicated simulation facility, as discussed. There are education and research efforts around this, novel simulation methods that we're incorporating. And some newer developments, as I discussed, this case-based conference, robotics curriculum by year, which includes our robot simulation that the residents can go and practice on and have curriculum that they're following. And then video review and coaching as well. And Dr. LeCompte, who's pictured here, has been very instrumental in rolling out the robotics curriculum. And we do have an actual robot in the simulation lab, as I said. We also have access to teaching consoles in the operating room. This is just a picture of our team, our residents learning in the simulation lab. We had a robot lab basically over the span of 2 days with the Journal Club and a lot of simulation. We got to operate on chickens and other fun things. And they really enjoyed that and really loved it. And that's something that will continue in the spring as well. We also have access to our really amazing new medical school building. that just finished construction, and there's some really amazing simulation stuff available in the medical schools. So we run our asset and best courses there, which are for the senior residents. These are basically cadaver courses where we say, hey, the patient got shot in the arm, shot in the chest, and the residents operate and basically expose the blood vessels to obtain access to the vessels. The best course is a REBOA course, teaching how to properly and safely place REBOA. And then one of the things that we always do for our interns when you come in is an orientation to get you used to like what it's going to be like to be an intern. And part of that is a boot camp where you, for a day, go and do kind of a team building exercises ropes course. Now, you don't have to climb anything if you don't want to, obviously, but there are lots of activities that are team activities. It's kind of a way to have icebreakers, get to know your team well, because these are the people you're going to be relying on for the next 5 to 7 years as you go through the program. And so it's a way to really learn who they are and get to know them before the whole year starts. So this is a course that we've been running as well over the past 20 years, and it's an annual Residents as Teachers conference where you spend the day, dedicated time, learning with a faculty member. And this year we had Dr. Tarun come from Vanderbilt, and the residents really get a lot out of learning how to become effective teachers, how to become leaders in the education space. So we really take resident feedback very seriously. We have the residents do peer evaluations at the end of each rotation, as well as faculty and rotation service evaluations. And so they're completed after every rotation, but they're summarized after about 6 months to preserve anonymity. Everything's anonymous. And so that's really important to make sure that we get like honest and reasonable feedback. And these are used in consideration of faculty career progression, awards and compensation, program improvement, and really ways to know how can we as faculty be better teachers and leaders. There's a yearly program evaluation as well. And then I think one of the most important things for me is these weekly to every other weekly meetings with the program director with different PGY levels. And it's really a way to get feedback on things you like, things you don't like, brainstorming and problem solving about issues that we're having. And like I said earlier, you do have quarterly meetings with the department chair as well. And so I think, like I said before, one of our strengths really is those relationships that you form. The residents and faculty work together, we play well together. I would say probably about once a month there's a program-related sponsored event. Here's a pumpkin carving party I had for the PGY 2s and 3s last month, which was a lot of fun. There's a annual Duke softball game in the spring, which the funniest part about this was back when this first got started, Duke won multiple years in a row. I think it was like 3 years in a row that they had won. So that 1 year they brought this massive trophy, and then from then on, that trophy has pretty much lived in our department. And so here are all the states where current UNC surgery residents attended medical school. So you can see it's a fairly broad spectrum of places that our residents have come from. Which really highlights the fact that we are a national program. We have people coming from all over the United States to train here. And so, you know, we're not just looking for people from the Southeast or the East Coast. We really want people from all over, and it doesn't matter where you come from. We look at everybody the same. And here's just some more pictures of our residents there, the PGY 3s over on the left. And then over on the right, I think this was our St. Patty's Day party that we had last year. So one of the other things I'm pretty proud of in terms of our program is the diversity of our resident group. So we're about 50-50 male-female, which if you look back over the 15, 20 years of the past 15, 20 years of the program, we've been pretty consistently about 50-50, which is, above the national averages for women in surgical training. Our faculty recruitment has been very strong for women as well, and we're not quite at the 50-50 mark for faculty, but we're about 30% female, which is above national averages. Similarly, for underrepresented minorities in medicine, we're about 40% on the resident side, which is marvelous. I mean, it's well above national averages. And the faculty, we're above national average as well. 50% of the residents are married and about 20% have children. So we have a broad group from a lot of different backgrounds and at a lot of different stages in their lives. So following residency, the vast majority of our residents do go into fellowship. Since about 2006, 80% have gone into fellowship. More recently, I would say that the vast majority choose to do a fellowship, but we still occasionally have people going into private practice directly or going into Navy or Army positions. Here is a picture of our current chiefs who are running the show. Here is a group of our graduating residents from last year and where they have gone to fellowship. So you can see there's a broad spectrum of things that people are going into. We have some critical care, cardiothoracic, surgical oncology, vascular, and so a lot of different programs across the country. And one of the things that I think is a strength of our program here as well is that our residents historically can get into any fellowship program that they're trying to get into, and they're going to strong national programs and matching where they want to match. And I'm not going to read kind of all through this, but this is the 2022 Chiefs and all the places that they've gone to. Of note, we do have a variable number of graduates every year because we aren't a mandatory research institution. So you may notice that sometimes they're 6 people, sometimes they're 8 people. Here's our 2021 Chiefs and their fellowship locations. And you'll notice, again, like as I said, a cross-section of specialties that people are going into: pediatric surgery, colorectal, thoracic, critical care, surgical oncology. And then this is the last group, the 2018 Chiefs. And what I love about this picture is that Dr. Myers, who's the previous program director, loved Diet Coke, and so the Chiefs broke into his office and are all drinking Diet Coke out of his fridge, lounging in his office. The department's commitment to surgical trainees is pretty broad. So obviously we support clinical development, but we also support professional development. So we have sessions for the residents revolving around, what it means to be an attending, coding and billing and things of that nature. We obviously support the academic development, that's that research time. Formal mentoring programs do exist. We have a mentorship program where the PGY1s who come in are matched up with an attending, and they will meet regularly throughout the year, focusing on things like, the clinical development, goals for the year, academic plans, for research and research time, as well as fellowship. We do have support for academic activities, so residents who want to go present at national meetings, present their work, we fully support that. We support the residents financially. There's some policies around that in the department. Our wellness committee is administrated by Dr. Tim Farrell, who's the vice chair of education. Obviously, wellness is really important to us. We want our residents to be healthy. This is a broad program focused on education and activities, and it incorporates both residents and attendings on the committee. We likewise have a diversity committee, and I'll talk a little bit more about that later, but we have a strong commitment to diversity as well as a strong commitment to fun. So, it's well and good to talk about wellness in the residency, but I think having time outside of the residency to have fun and to interact with your fellow residents in a setting that is not the hospital is really important. So here are just some pictures of one outing we had to a local brewery with everybody brought their puppies. That was a lot of fun. And then down over on the right side here are a bunch of our 4th and 5th year residents at the end of year graduation party. So one thing that needs to be said about Chapel Hill is it's just a great place to live. So it's situated right in the middle of the state and is in the Research Triangle Park. So there's a lot of collaboration, research, intellectual curiosity in the area, and it's just a really cool place to live. It's equidistant from the coast and the mountains, so it's about 3 hours-ish to get to the beach and 3 to 4 hours to get into the mountains. There's hiking trails and biking trails all over Chapel Hill, and it's just a really wonderful place to live. Most of the residents can live pretty close to the hospital, so for that reason, they can take a lot of home call, which also I think helps with wellness. But it's just a wonderful place to be. And as I said, there are a million things to do in Chapel Hill. A lot of it is outside activities. There's a ton to do outside because the weather's so nice. But for those of you who are foodies, there are local breweries and restaurants within Chapel Hill, as well within Durham. There's a great music scene at the Cat's Cradle, and that's in Chapel Hill in Carrboro. And Durham has the Performing Arts Center, museums all over the place. It's just a really great place to live. The school systems are really great too for those of you who have children. So I just want to touch a little bit on research in surgery and some of the opportunities there. Here are some of our residents presenting at the American College of Surgeons. And here are a couple more pictures from the American College of Surgeons this year. So I want to talk a little bit about optional research time and what that looks like. So in general, it is after the PGY3 year, and it's 2 years. Occasionally people will do 3 years. We've never had anybody do 1 year, but I suppose it would be a potential option if the numbers worked out with the residents coming in and out of the lab. Here's a view of the number of residents who are in research each year. So generally it's been about 7 per year over the past several years, and that includes residents who are in their first year of research as well as the ones who are in their second year of research. One of the things I love about the research opportunities in our department is that it's incredibly broad. So it can include, health services research, health outcomes, global surgery, basic bench work, translational, QI, education simulation. We've had people do all sorts of things. Kevin, one of our current PGY4 residents, worked with a faculty at UNC who is in computational biology and informatics and did some really cool things with AI and machine learning. We have multiple faculty with NIH funding, several T32 training grants, specifically in trauma and cancer. And just because we're surrounded by so many departments and schools, there are many, many opportunities for funding and training grants on campus that we also use. We have the SHEP Center, NC Tracks, departmental statisticians, lots of different groups and organizations who can help our residents achieve their research needs. Funding, I will say, is never really a problem and is really one of the strengths of our program. We have never had issues getting our residents funded. Um, One of the strengths of our program also is, I think, that flexibility that if you want to take this time to do research, you can, but you also have that option to not participate and go straight through the 5 years. Um, the School of Public Health is a really great opportunity. You can get a master's in public health in 1 year as a resident here. Um, our School of Public Health is #1 in terms of public schools of public health in the nation. It's tied for #2 overall School of Public Health in the nation. Um, and that school has a ton of funding and is a really great opportunity for our residents who are interested in getting a master's while they're here. We have a sizable global and public health effort as well through the department in terms of collaboration with Malawi. So this collaboration initially started off with infectious disease and OBGYN, but now we have a very large surgical footprint in Malawi. Um, and it's just a really cool collaboration. So it's with the Kamuzu Central Hospital in Malawi. Dr. Charles started this back in 2007 and really, built this collaboration. He built a surgical residency for the local Malawians from the ground up, and the hospital is self-sufficient from a surgical standpoint at this point. Those residents who have come through that program are now the faculty at that institution, and we go there and do research and operate and collaborate with our colleagues there. And so here's a picture of Dr. Charles, and this is Dr. Gallagher, who was a resident here as well as now one of our trauma critical care faculty, who is extremely involved in the efforts in Malawi. And I've done some research in Ghana as well. And we have a list of all the residents over the years who have been involved in Malawi. These are the folks pursuing dedicated research time currently. Over on the right side of the screen, you'll see Dr. Chase Cox is working with Dr. Gita Modi, one of our thoracic surgeons, with a T32 grant as well as some NIH funding. Dr. Mustafa Abid is working with Dr. Anthony Charles with a T32 grant. Dr. Topher McCauley is actually out at Northwestern right now at the Children's Hospital working with some of the surgeons there. In the second year, we have Dr. Ursula Adams, who's working with Dr. Udek Wu, who's at Wake Med, is one of our surgeons at Wake Med. Selena An, Dr. An is working with Dr. Charles in Malawi. Dr. Taylor Carter is working with both Dr. Luigi Pasquarella and Dr. Bridget Smith. She is getting her master's in education and doing a lot of interesting work around education. And Dr. Hannah Trembath is doing basic science research with Dr. Jen Ye. So we do want people to be involved in research even if they aren't taking the dedicated research time. So our goal is to have all of our residents complete 3 or more manuscripts by the end of residency, and at least 1 during the first 3 years. You can see here some pictures over to the right of our annual research day with residents and attendings looking at the residents and medical students' work. During the PGY 1 year, all of our residents meet with Dr. Ye during the first quarter, who is our vice chair of research. They identify mentors and projects, discuss whether or not they're going into dedicated academic development and research time. Usually at the kind of mid-PGY2 year in December, the residents have to decide if they're going to do the dedicated academic research time. Proposals are developed basically during that second half of the PGY2 year, including funding sources and extramural grant applications. Research time will then generally begin after the 3rd year. And then we have a lot of resources to help you do this. So Dr. Ye has a bunch of resources set up on the website. This includes access to national databases, access to our department biostatisticians who can help do stats, grant support, and how to go about applying for grant funding. So I want to switch gears a little bit here and talk about some of the changes that we've had more recently in the residency. So resident wellness is really important to us. It's been a cultural change for our department and program over the past 5 to 10 years. We've done a number of things to try to improve wellness, including implementation of personal care days. And so the residents know they have these days far in advance so they can schedule doctor's appointments or just take time off to kind of get sleep and rest. And this has been really instrumental, I think, in reducing resident burnout. We also have more defined coverage systems in place for absences. And one of the things I think the residents are really great at is supporting each other and stepping up to help out when if a resident has to take time off. There's no complaining. Everyone's like, oh, I'll help out. We have trainee wellness resources, including taking care of our own program, which is accessed via our website, which you can make appointments to talk to a therapist. We have made significant changes in institutional GME parental leave policy. So it used to be that if you were taking parental leave, you had to use your vacation time and non-paid leave. But now we basically have a policy that preserves vacation time and leave is paid. And the leave is for parents in general. So paternity leave, maternity leave is fine. We have multiple people this year throughout the program taking maternity leave and paternity leave. And as you can imagine, a really big part of wellness is being able to have a life outside of the hospital and have fun with friends. And you'll notice a lot of the pictures we have are of residents hanging out outside the hospital with each other because we all get along very well. So this is our ugly holiday sweater party we had last year, which had a really good turnout. Ultimately ended up being some 30 or 40 people at that. And here's some other pictures from our spring party and our fall party this past year. And you can see Will here has his tiny, like several week old baby that he brought to the party. So I think it's important to state that we have a strong emphasis on diversity, equity, and inclusion in our department. Dr. Luigi Pasquarella is one of our vascular surgeons and has led up our departmental emphasis on diversity as the vice chair of diversity and also heads up our committee, which most of our program leadership, including myself, are a part of. I think it really needs to be said that our patient population, the general population, is incredibly diverse, and we want our workforce to also reflect that diversity. We want people to come here and feel welcomed and included and part of our family. And our family is very varied and diverse, and we really celebrate that. We are aware, of the biases that may be present in reviewing applications, and so one of the things we've done this year is develop a resident selection committee. So we've really tried to negate some of these biases. That committee is super diverse in terms of backgrounds and experiences, includes residents and faculty. This year, that selection committee reviewed every single application that we received using a holistic approach. The faculty and residents were blinded to step scores, race, ethnicity, and gender as best we could. All selection committee members underwent unconscious bias training prior to reviewing applications. You may note during your interview process that some residents are involved in the interview process, and you also may note that some of the faculty, not all of them, but some of them, including Dr. Greenberg, are blinded to the majority of your application and have standardized interview questions so that you're really just having a conversation. some changes in the residency program on an education and mentorship standpoint. We are transitioning to entrustable professional activities, which is happening all across the board throughout general surgery residency programs. This is, I think, going to be a really great thing in that it's basically done on a simple phone application, and residents can get actionable, timely feedback following cases and consults. So you do a case and you send a ping to your faculty member who gives you feedback on that case immediately in real time. Another kind of education change, which I already talked about, is the new weekly lunch case-based conference, as well as the quarterly video review conference. So watching videos of different operations and giving feedback on how to improve on that operation. We're trying to extend that out also to trauma resuscitations. There's a new robotics curriculum, as I also discussed, that will be tailored to each year of training so that you progress in the robotic training as time goes on. And then another idea, which I credit to Dr. Farrell, who's our Vice Chair of Education, is developing mentorship houses, almost Hogwarts style houses across PGY levels. So different groups of residents to mentor and support each other. And we'll have kind of fun activities around that too, FLS competitions, robotic competitions, and ways to really encourage peer mentorship. Some rotation changes that are coming up. So in 2022, we developed the PGY5 elective rotation, which we're going to continue, and that has been really well received. In 2023, we've been working on specific expectations for residents and faculty by PGY level and service, so that everybody knows what they are expected to learn when they rotate through colorectal surgery, transplant surgery, etc. Something that will be coming down the pipeline next year, as I had mentioned, is that we will try to expand the night float system for the PGY2 year. So there's less 24-hour call, and the residents have really been clamoring for this. So that is something that's born out of resident feedback. And then obviously we have a new department chair, Dr. Caprice Greenberg, who joined us in 2022. She has some incredible ideas on expanding our clinical footprint, collaborating across the state of North Carolina. She's an incredible advocate for training, and especially around this idea of surgical coaching for both faculty and residents. She's involved in the Board of Surgery, American Board of Surgery, with her ideas around coaching, and has a lot of experience and has published extensively on this. We're going to be involved in the multi-institutional trial around surgical coaching. So I'm really looking forward to her ideas moving forward, and ways that this is going to really affect our training program in positive ways. Other things, we have a new surgical and ICU tower that has felt like it's taken forever to develop, but it is finally going to be completed basically in the spring, and the opening date is for May 2024. So when y'all arrive, it'll be ready to go. And here are some just mock-ups of what that is going to look like. So it's pretty cool. The ORs are a lot bigger. There's new technology, a lot of space. It's going to be really incredible, and some of the old ORs are going to be turned into procedure rooms, etc. But this will be here when y'all come. People often ask me, what are we looking for in a resident? And so we really want people who want to be excellent, who strive for self-improvement, and for excellence. We want leaders in the surgical realm, both at a program, institutional, and national level. And we want people who have a strong commitment to professionalism and integrity, who are honest, stand up for their mistakes, stand up for other people, and have a commitment to improving the program, who want to look at the program and say, oh, how can we make this better? And who are team players. So if you're very individualistic, it might not be the best fit for you. We like people who are team players, who are work well in a team and help their fellow residents out and lift other people up. I think fundamentally, I'm really looking for people who are intellectually curious, who are passionate about operating and becoming clinically excellent, but who are also passionate about advancing surgery in a bigger picture in some sort of way, be it scientific discovery, improving quality or larger public health measures, improving care for underserved populations, biodesign, global trauma systems, improving education methods, increasing diversity in the healthcare system. There's no one thing or set pathway that you have to be on, but I want to see people who are fired up about some bigger picture. And probably most importantly, we are one big family in this program, and so the most important thing, the highest number one thing for me, is finding people who are kind and compassionate people who want to make the world a better place. That is really what I think our residents embody. I want the resident who's going to, be leaving the hospital after their work is done, who sees their fellow residents struggling or overwhelmed, and with zero benefit or advantage to themselves will stop and help their fellow resident. Um, I often find that, the people who are lifting other people up around them are the ones who end up elevated themselves as well. And that's really what our program is all about. And our vision statement is to be the nation's leading public academic department of surgery. And I really do think our program mirrors this, and we've done a good job towards that goal. I think there's more that we can do, which is why we have resident feedback, and we're always striving to improve the program. Um, and then this is obviously, a big thing at UNC is basketball, and we used to have, when y'all would come and actually interview in person, we would take a trip to the basketball museum and have lunch there. Um, and obviously, while that's not possible in the virtual arena, we will have a early February second look for those of you who are interested, where you can actually come in person and see the campus. It is not compulsory at all. We will not be taking attendance, will not affect how you're ranked, so we won't know who's all coming, but it will just be a way for people who haven't been here before and want to check out the area, or who want to get to spend time with the residents and get to know them, to come and see what we're about. And really, all we'll have you do is come spend time with the residents and get a feel for the program. We envision it kind of as a Friday walk through the hospital with the residents, and an evening informal gathering at one of the residents' house to kind of meet and get to know them. Zero pressure. You won't meet any faculty. We will not know who has come or not. Like I said, we're not taking attendance or track who's coming and going. It's not an interview. It's just a resource for you, because it's really difficult, I think, to get an idea or a feel for a program virtually. So hopefully that will kind of help give you a little bit of an overview of the program. And obviously, we'll have a session before the interviews start. We'll have about an hour to talk to some of the program leadership, and you can feel free to answer questions. So please bring questions to our live Q&A session, which will happen in the 12 to 1 o'clock hour before we do our resident interviews. And I look forward to meeting you all in person, and welcoming you to UNC virtually.